there is a belief almost everyone has heard about blood pressure. One number, one perfect target, 120/80. For years, many people have been told that if you can reach that number, you are automatically safer. And if you're older, the message often sounds even more urgent. Get it down, keep it down, lower is better. I want to slow that down and look at the whole picture, especially for adults in the 65+ range. Here is what I recommend we do together in this video. First, we will talk about why older bodies respond differently to lower blood pressure. Second, I will share a few realistic stories that illustrate what can happen when a number looks good on paper, but the person does not feel good in daily life. Third, I will give you practical, non-dramatic steps you can use to have a smarter conversation with your clinician, including a simple way to check whether standing up is creating a big pressure drop. And I will be very clear about something up front. I am not here to diagnose you, and I am not here to tell you to change medication on your own. My goal is to help you understand your own signals, track your numbers correctly, and ask better questions. Now, before we talk about any targets, you need to understand one key idea. For many older adults, the most important goal is not chasing a textbook number. The most important goal is staying steady, staying clear-headed, staying safe on your feet, and protecting daily function. A reading can look impressive, but if you feel light-headed when you stand, if you are moving cautiously because you do not trust your balance, that matters. Those are signals worth taking seriously. Let me tell you a story that captures why this matters. Eleanor was 78. She had been told years earlier that her pressure was higher than ideal. At the time, her numbers were around 152/88. Her clinician started one medication. After a short period, her home readings moved down to around 138/82. Everyone felt encouraged. Progress. But the message was still the same. Get closer to 120/80. So the dose was increased. Later, a second medication was added. Slowly, the number in the notebook started to look beautiful. 122/78 at home. At first, Eleanor thought she was doing great. She felt a little tired, but she assumed that was normal. Then she noticed something odd. When she stood up from a chair, the room felt like it shifted for a moment. Just a few seconds. Then it passed. She mentioned it. The answer she got was simple. Stand up slowly, take your time, drink enough water. Eleanor tried. She stood up carefully, but the feeling kept showing up. Every time she got out of bed, every time she rose from the couch, and something else started happening that is easy to miss. She began to fear simple movement. Not panic fear, quiet fear. The kind that makes you hold on to the counter. The kind that makes you hesitate before walking across the room. One morning, she got up to go to the bathroom. She stood, and that spinning sensation hit harder than usual. Her knees buckled. She reached for furniture, missed, and went down hard. At the hospital, the team checked her pressure in different positions. Lying down, it looked fine. Sitting, it was lower. Standing, it dropped dramatically. This pattern is called orthostatic hypertension, which simply means the pressure falls too much when you change position. That fall changed everything. Recovery took time. She needed help with basics for a while. She became less confident. She moved less. Her world became smaller. I am not telling you this to scare you. I am telling you because this is exactly the kind of situation that can happen when the focus is only the number, and nobody steps back to ask, how is the person doing? Here is the question I want you to hold in your mind. How can a number that looks perfect create a situation that is clearly not perfect for the person living with it? The answer is that one target does not fit everybody, especially not in older age. And the reason is not mysterious. It is physiology. The body changes over time in predictable ways. Let us talk about why. First, blood vessels become stiffer with age. When you are younger, your arteries are more elastic. They can expand and adjust quickly as your heart pumps. As we age, those vessels tend to stiffen. That changes how pressure behaves through the day. It can also change how well the body adapts when you stand up. A pressure that is fine for a younger adult may not provide the same steady flow for an older adult who needs a little more support to keep blood reaching the brain during position changes. Second, the sensors that help regulate pressure can become less responsive. You have pressure sensors in your blood vessels that help your body react quickly when you stand. In younger bodies, the response is fast. Vessels tighten, heart rate adjusts, pressure stabilizes. In older bodies, that response can be slower. So if your baseline pressure is already quite low, you have less cushion when you stand, and you may notice lightheadedness. Third, medication effects can be stronger in older adults. This does not mean medication is bad. It means dosing often needs more careful adjustment. Kidney and liver processing can change over time, and that can make the same dose feel different at different ages. Fourth, the risk calculation changes with age. In midlife, the major concern with higher pressure is the long-term wear and tear on the heart, brain, and kidneys over decades. In later life, the immediate risks of feeling unsteady, falling, or losing confidence in movement can outweigh small theoretical gains from pushing the pressure very low. This is not about ignoring cardiovascular protection. It is about balancing it with stability and quality of life. So what is the right number? I am going to give you a reasonable range, but I want you to hear this carefully. Targets for older adults are often best thought of as ranges, not as one magic number. And your personal range depends on your overall health, how steady you are on your feet, what other conditions you have, and how you feel day to day. Before we get into numbers, I want to share two shorter stories that show why personalization matters. Harold was 72. His pressure was around 146/88. Medication lowered him to around 124/78. On paper, great. In real life, he felt drained, lightheaded, foggy. He stopped enjoying normal activities. When his regimen was adjusted, his pressure rose modestly to around 136/82. He felt like himself again. Energy returned. The lightheadedness eased. The point is not that 146 was perfect. The point is that the aggressive push to a single target created a daily life problem that needed attention. Now Margaret was also 72, but she was not the same person as Harold. She had more medical complexity. For her, staying in the mid-140s carried more risk, so the plan focused on a slightly lower range, while closely watching for lightheadedness and position changes. Same age, different context, different plan. This is how good care is supposed to work. It adapts. Now, I want to explain one more important concept because it helps you interpret your readings. There are two numbers in a blood pressure reading. The top number is systolic. This is the pressure when the heart pushes blood out. The bottom number is diastolic. This is the pressure when the heart relaxes. In older adults, systolic often rises because of vessel stiffness, while diastolic can stay the same or drift lower. This creates a wider gap between the two numbers. A wider gap can be common with age. What we want to avoid is pushing the bottom number too low, especially if that creates symptoms or worsens steadiness. Very low diastolic can be a concern because the heart itself receives blood flow during the relaxation phase. Now, here is the practical part. What matters most is not just your sitting number. What matters is how your body behaves when you change position. If you often feel lightheaded when you stand, if you feel a quick spin, if you need to pause and grab support, that is not something to brush off as just getting older. I recommend you treat it as a useful signal. In the next part, I will give you safe ranges that many clinicians consider reasonable for older adults, and I will show you a simple home check for position-related drops that you can bring to your next appointment. Now let us talk about what the research and real-world experience often suggest for older adults without turning it into a one-size-fits-all rule. Many guidelines and older habits in medicine were built from studies that leaned heavily on middle-aged adults. That does not make those studies useless. It simply means the results do not always translate perfectly to people in their late 70s, 80s or beyond, especially if they are more sensitive to medication or less steady on their feet. What newer data has highlighted is something many older adults already feel in their bodies. If pressure is pushed too low, some people begin to feel less stable. They may feel more tired, less clear, or more cautious with movement. And when caution turns into less walking and less activity, the body can lose conditioning. Strength and confidence often matter as much as the number on a screen. So instead of treating 120 over 80 like the only acceptable destination, it is often more helpful to think in ranges based on age and overall condition. Here are reasonable ranges many clinicians discuss when the person is an older adult and the priority is both cardiovascular protection and day-to-day steadiness. If you are roughly 65 to 75 and you are active, steady, and do not have major medical issues, a common reasonable goal is systolic in the 130 to 140 range, with diastolic generally around the 70 to mid-80s. Some people in this group can sit a little lower if they feel great and stay steady. But there is no prize for chasing a number that makes you feel worse. If you're roughly 75 to 85 and still fairly robust, a reasonable goal can drift slightly upward, often around 135 to 145 systolic, with a diastolic that stays comfortably above the mid-60s. Again, the key is how you feel and how you move. If you're over 85, or if you are more frail at any age, many clinicians prioritize fall prevention and daily function, and may accept systolic in the 140 to 150 range if that is what keeps you steady and clear. In this group, aggressive lowering can sometimes cause more problems than it prevents. Now, there is an important nuance. If you have conditions such as diabetes, prior cardiovascular events, or reduced kidney function, the target may be adjusted. Often the plan aims for a moderate range rather than very low numbers, and the most important piece is monitoring how you tolerate that plan, especially your position changes. This is why I recommend you focus on two things at home: your average pressure over time, not one isolated reading, and your position response, lying, sitting, standing. Because for many older adults, the most dangerous situation is not a moderately higher sitting number. The more dangerous situation can be a big drop when you stand. Let us go practical. I am going to describe a simple home check you can do safely using a standard blood pressure monitor. If you do not feel comfortable standing without support, do not do this alone. Do it with someone nearby. Safety first. Step 1. Rest lying down for 5 minutes. Calm breathing. Then check your blood pressure. Write it down. Step 2. Stand up. Do not rush. Once you are standing, check your pressure again. If your device takes time to inflate, stand near a chair or counter so you can steady yourself. Step 3. Compare the numbers. A significant drop is commonly defined as a systolic drop of 20 points or more, or a diastolic drop of 10 points or more. If you see a drop in that range, especially if you also feel lightheaded, that reminds you and your clinician to review the plan. It may mean the current regimen is a bit too strong for how your body handles position changes. This is not a reason to panic. It is useful information. I want to give you a story that shows how powerful this simple check can be. Thomas was 74. His sitting numbers looked impressive, around 128/76. His clinician was pleased. But Thomas kept saying he felt light-headed when he stood. If you only look at the sitting number, you might dismiss the complaint. But when Thomas checked lying and then standing, the pattern was clear. His standing pressure dropped significantly. That explained the symptoms. With careful adjustment, his sitting number rose modestly, but his standing number became much more stable. The lightheadedness improved, his confidence in daily movement improved, and in his case, that trade-off made sense. Now let us talk about the overall protocol I recommend you bring to your next appointment. This is the part that helps you stop guessing. Protocol Step 1. Measure correctly and consistently. Take readings at home, ideally morning and evening, for about 2 weeks. Sit quietly for a few minutes before checking. Use the same arm. Keep the cuff at heart level. Write down the numbers and the time. This creates an average which is far more useful than a single office reading. Protocol Step 2. Check position response. Do the lying to standing check at least once or twice during that 2-week window, especially if you ever feel lightheaded when you stand. If you see a big drop, write it down and share it. Protocol Step 3. Track symptoms. I recommend you keep a simple note. Any lightheadedness, fatigue, brain fog, unsteady feeling, or new caution when walking. Also note if you feel great and steady. Clinicians need both numbers and lived experience. Protocol Step 4. Consider your full picture. Your age, your mobility, your history, your kidney function, your medication list. The right plan is not just about blood pressure. It is about your whole system. Protocol Step 5. Discuss targets as ranges. Instead of arguing about a 120/80, ask for a target range that matches your life and your body. Ask what the plan is if you develop symptoms. Ask how your standing pressure should look. Protocol Step 6. Adjust slowly and carefully. If your clinician changes something, it is usually safest to change one thing at a time, then recheck the averages and recheck the position response. This prevents confusion about what caused what. Protocol Step 7. Reassess over time. What works at 70 may not be ideal at 80. I recommend revisiting the plan every 6 to 12 months, or sooner if your steadiness changes. Now I want to address a common worry many people have. My clinician insists I must be at 120/80. If this is happening, I recommend you approach it calmly and collaboratively. Bring your home log. Bring your position results. Bring your symptom notes. Ask a simple question. How do we balance cardiovascular protection with my day-to-day steadiness? What is our plan if I feel lightheaded? Can we agree on a range that keeps me functional? Most clinicians respond well to a patient who brings clear data and asks clear questions. Another common worry is this. I am on several medications and my pressure is still not at the textbook number. Here is what matters. Do you feel steady, clear, and capable in daily life, and what is your average range? Adding more medication can help in some situations, but it can also increase side effects in others. This is exactly why the home log and position check are so valuable. And one more important point. Look out for what is sometimes called white coat effect. Some people show higher numbers in a clinic because of stress and normal numbers at home. Others have the opposite pattern. Home monitoring helps you and your clinician avoid overtreating or undertreating. In the next part, I will tie everything together with a few more examples, a simple summary you can remember, and a calm way to act on this information without making sudden changes. Now let us bring everything together in a way that is easy to remember and practical to use. The most important idea I want you to take from this video is simple. Blood pressure in older adults is not about chasing a perfect number. It is about finding a range that keeps your organs supported while also keeping you steady, clear-headed, and confident in daily life. Numbers matter, but how you feel and how you move matter just as much. Let me share a few more real-life situations that show both sides of the equation. Patricia was 76. Her pressure had been pushed down into the high teens over low 70s. On paper, it looked excellent. In daily life, she felt weak, lightheaded, and mentally slow. Simple tasks felt overwhelming. When her pressure was checked lying and then standing, the drop was significant. After careful adjustment, her average pressure settled in the high 130s over upper 70s. The position drop improved, the lightheadedness eased, her energy returned. She felt like herself again. The number was higher, but her function was better. Now consider George, who was 81. His pressure was clearly higher than ideal by traditional standards, but he was active, independent, and steady. After discussing risks and benefits, the plan focused first on gentle lifestyle adjustments rather than immediate medication changes. His pressure improved modestly and, more importantly, he remained confident and active. In his situation, the balance favored stability and independence. What these situations show is that the right decision depends on the whole person, not just the reading. There is a phrase often used in care of older adults: treat the person, not the number. That phrase exists for a reason. A pressure that is too high for one person may be acceptable for another. A pressure that looks ideal for one person may create symptoms in someone else. Context matters. Now I want to address a concern many people quietly worry about: memory and thinking. Some research suggests that very high blood pressure in midlife can affect brain health years later. At the same time, other research has raised concerns that very low blood pressure later in life may reduce blood flow to the brain. This does not mean lower pressure is always bad. It means extremes in either direction may not be ideal. For many older adults, moderate pressure appears to support better brain perfusion over time. This is one more reason why blindly pushing pressure very low in late life may not always be the best approach. Another practical issue is measurement accuracy. Clinic readings are useful, but they are only one snapshot. Stress, rushing, and unfamiliar environments can temporarily raise pressure. This is why I strongly recommend home monitoring when possible. It gives a truer picture of your usual range. On the other hand, some people have normal readings in the clinic, but higher readings at home. That pattern also deserves attention. Home monitoring helps catch both situations. Now let me give you a clear summary you can remember and share. For many adults over 75, systolic pressure in the 130 to 140 range is often associated with good balance between protection and daily stability. Pressures consistently below 120 in older adults may increase the chance of lightheadedness, position-related drops, and reduced steadiness, especially if symptoms are present. Pressures consistently above 150 may increase other risks over time and should be discussed thoughtfully. For adults 65 to 75, ranges can be slightly lower if well tolerated, but symptoms and position response still matter. For frail older adults at any age, preventing falls and maintaining independence is often the top priority, and slightly higher ranges may be appropriate. Diastolic pressure should generally stay comfortably above the mid-60s. Very low bottom numbers deserve attention. Position-related drops are a key signal. If your pressure drops significantly when you stand, that is more important than how good the sitting number looks. Targets should be revisited as you age. What works now may need adjustment later. And most importantly, never make changes on your own. Use this information to guide conversations, not to self-adjust. If you take one action after watching this video, I recommend this. Start a simple home log, morning and evening readings for 2 weeks. Add notes about how you feel. Do 1 or 2 position checks if you ever feel lightheaded. Bring that information to your next appointment. That turns the conversation from guessing into problem solving. It also shifts the focus from chasing a number to supporting your life. If you have ever felt that your concerns were brushed aside because the number looked good, you are not alone. Many people experience this. Calm data and clear questions help bridge that gap. Remember, the goal is not perfection on paper. The goal is steadiness, clarity, confidence, and quality of life. If this explanation helped you understand your blood pressure in a new way, save this information and return to it when you review your readings. Share it with someone you care about who may be struggling with similar questions. In future videos, we will continue talking about how aging bodies change, how to interpret signals correctly, and how to work with your care team to make decisions that support your independence. Thank you for staying with me through this full explanation. Now you know that blood pressure targets can and should change with age, that ranges matter more than single numbers, and that your lived experience is a critical part of the picture. I will see you next time, and we will continue building understanding step by step, calmly and thoughtfully.